In my 20 years in the operating room, I have watched families stand at a bedside and say the same sentence over and over, "It happened so fast." But here is the truth most people never hear. A stroke rarely begins with a dramatic collapse. It begins quietly, subtly. A dropped coffee cup, a word that won't form, a face that doesn't quite move the way it should. And what you do in the first 3 minutes can profoundly influence what I later see on a CT scan. There is a widely accepted belief that when a stroke starts, there is nothing you can do except wait for the ambulance. Just sit there, just hope. That belief is incomplete. And in my clinical experience, it costs people brain tissue they cannot afford to lose. Every 40 seconds in the United States, someone experiences a stroke. What is almost never discussed is this. Brain cells begin to suffer within minutes of oxygen deprivation. Neurons are metabolically demanding cells. They rely on a constant delivery of oxygen and glucose through the cerebral arteries. Interrupt that flow, even briefly, and ATP production inside those cells begins to fail. Iron gradients collapse, swelling follows, damage accumulates. I have opened skulls to relieve pressure from that cascade. But I have also seen something else. I have seen patients who arrived with symptoms already improving, speech returning, weakness lessening, and when you dig into the timeline, there was a narrow window where their body was still compensating, where circulation had not fully failed. That window matters. Let me paint a scenario. A 68-year-old woman is making coffee. Suddenly her left arm becomes heavy. Words fragment. The right side of her face droops. These are not vague signs. They represent disruption in the middle cerebral artery territory, the vascular highway that supplies motor and language centers. Most people freeze. Some try to walk it off. That hesitation is dangerous because in the earliest phase of an ischemic stroke, before a clot completely obstructs flow, there can still be partial perfusion. Collateral vessels may still be delivering limited blood supply. Your body has backup routes, but they need support. And this is where positioning and controlled breathing become clinically relevant. I am not talking about replacing emergency care. I am talking about buying time, supporting cerebral perfusion while help is on the way. In surgery, we constantly use positioning to influence blood flow. Gravity is not trivial. Elevating or lowering parts of the body changes venous return, cardiac preload, and ultimately cerebral blood delivery. These are not alternative concepts, they are foundational physiology. The first step when symptoms appear is safety. Sit or lie down immediately. Prevent a fall. Then, if possible, lie flat and elevate the legs approximately 12 inches. This encourages venous blood pooled in the lower extremities to return to the heart. Increased venous return can modestly improve cardiac output, and cardiac output drives cerebral perfusion pressure. At the same time, slow, deliberate breathing becomes critical. Inhale through the nose for 4 seconds. Hold briefly. Exhale slowly for 6. This is not mystical. Slow breathing modulates the autonomic nervous system. It reduces sympathetic surge, the stress response that constricts blood vessels. It helps stabilize blood pressure variability. It improves oxygenation. Panic tightens vessels. Calm breathing supports them. When seconds matter, these small physiological advantages can help sustain vulnerable brain tissue until paramedics arrive. Now, before we go deeper into the science behind why this works and what is actually happening inside the cerebral circulation during those first minutes, you need to understand something far more important. Your body almost always gives you a warning. Your body almost always gives you a warning. The problem is that most people misinterpret it. Let's go deeper into what is actually happening inside the skull during those first critical minutes. An ischemic stroke, the most common type, occurs when a thrombus or embolus obstructs an artery supplying the brain. In many cases, that clot originates in the carotid arteries of the neck, where atherosclerotic plaque has narrowed the vessel. Sometimes it forms in the heart during atrial fibrillation and travels upward. Either way, the end result is the same: reduced cerebral blood flow. Now, here is the physiological detail that matters. Brain tissue requires approximately 50-60 milliliters of blood per 100 grams of tissue per minute to function normally. When blood flow drops below about 20 milliliters per 100 grams per minute, neurons begin to malfunction. Speech slurs, limbs weaken, vision distorts. But cell death does not occur instantly. There is a zone neurologists call the ischemic penumbra. This is tissue that is underperfused but not yet irreversibly damaged. The core of the stroke, where flow drops below 10 ml per 100 grams per minute, may be lost quickly, but the surrounding penumbra is salvageable if circulation improves in time. That is the battlefield. Cerebral perfusion pressure is determined by mean arterial pressure minus intracranial pressure. In simpler terms, your brain receives blood based on how effectively your heart pumps and how open your vessels remain. When you panic, your sympathetic nervous system activates. Adrenaline surges, peripheral vessels constrict, heart rate accelerates inefficiently, breathing becomes rapid and shallow, which can reduce carbon dioxide levels too quickly. And here is a critical nuance. Carbon dioxide is a vasodilator in the brain. If you hyperventilate and blow off too much CO2, cerebral arteries can constrict further, potentially reducing blood flow to already vulnerable tissue. This is why controlled breathing is not trivial. A slow inhale through the nose, a brief pause, and a prolonged exhale help regulate CO2 levels. It stabilizes vascular tone. It prevents the excessive vasoconstriction that panic can trigger. In clinical settings, we carefully monitor CO2 for this exact reason. Now let's add positioning. When you lie flat and elevate your legs, venous return increases. Blood that was pooling in the lower extremities moves back toward the right atrium. According to the Frank-Starling mechanism, increased preload can enhance stroke volume, meaning the heart pumps more effectively with each beat, up to a physiological limit. More effective cardiac output can support systemic blood pressure and, in turn, cerebral perfusion. In stroke units, we are cautious about aggressive head elevation in early ischemic stroke for this reason. Lower head positioning can sometimes modestly enhance cerebral blood flow in certain patients. This is established hemodynamic science, not internet folklore. Does this dissolve a clot? No. But in that narrow window before complete occlusion or extensive tissue infarction, even slight improvements in perfusion can support the penumbra, the tissue that is hanging in the balance. There is another piece most people overlook: transient ischemic attacks, or TIAs. A TIA occurs when a blockage is temporary. Symptoms may last 30 seconds, perhaps a minute, then they resolve. Patients often dismiss them. But physiologically, a TIA represents unstable plaque or intermittent embolic activity. It is the brain sounding an alarm. The danger is not the brief symptom. The danger is the clot that comes next. Have you ever experienced sudden one-sided weakness or speech difficulty that resolved quickly and convinced yourself it was just fatigue? If so, that is not something to ignore. That is a vascular warning sign. In the operating room, I do not see the early warning. I see the aftermath. Swollen tissue, midline shift, loss of function that could potentially have been mitigated with faster action. So when I emphasize positioning and controlled breathing, I am not offering a miracle. I am emphasizing physiology, supporting venous return, stabilizing autonomic tone, preserving oxygen delivery. Because once neurons cross the threshold into irreversible injury, we cannot bring them back. In the next segment, I want to address a critical misconception: the standard response most people default to, and why delay is the most dangerous decision you can make. The most dangerous decision during a stroke is not the wrong breathing pattern. It is delay. I want to address the standard response I see over and over again. Let's wait and see if it passes. This is where physiology collides with human psychology. When symptoms are intermittent, when speech returns or the arm regains partial strength, people convince themselves the threat is gone. But clinically, that improvement often represents fluctuating perfusion. The clot may still be unstable, collateral circulation may be temporarily compensating, the artery is not necessarily clear. And here is the first major problem with waiting. Number one, the clot can propagate. A small thrombus can enlarge. Platelets aggregate. Fibrin strands stabilize the obstruction. What began as partial narrowing can become complete occlusion. When that happens, cerebral blood flow drops below the survival threshold. The ischemic penumbra collapses into infarcted core. At that point, we are no longer preserving tissue. We are documenting loss. Number two, the treatment window narrows rapidly. Intravenous thrombolytics, such as tissue plasminogen activator TPA, must be administered within a strict time frame to be considered safe and effective for many patients. Mechanical thrombectomy, physically removing the clot, also has time-dependent criteria. The longer brain tissue remains ischemic, the higher the risk of hemorrhagic transformation and poor recovery. When someone arrives at the hospital hours after symptoms began because they felt better, options become limited. Number 3, physiological stress compounds, injury. Panic elevates blood pressure erratically. Extreme hypertension can increase the risk of hemorrhagic conversion. On the other hand, a sudden drop in blood pressure can further compromise cerebral perfusion. Rapid, shallow breathing alters carbon dioxide levels, potentially constricting cerebral vessels. This instability is not theoretical. We monitor it continuously in stroke units. Now contrast that with a composed response. Immediate emergency activation, horizontal positioning, leg elevation if safe, slow regulated breathing, remaining still, avoiding unnecessary exertion. These actions support hemodynamic stability while professionals are en route. This is not about replacing emergency services. It is about not sabotaging your own physiology while waiting for them. There is another misconception I want to correct. Some people believe that moving around will get the blood flowing. They attempt to walk. They try to test their strength. I strongly advise against this. If one side is weak, a fall is a real risk. Head trauma on top of a stroke complicates everything. Additionally, exertion increases metabolic demand in already vulnerable tissue. Your brain is in an oxygen crisis. Do not increase its workload. From a surgical perspective, when I evaluate imaging after a stroke, I look at tissue quality. Is there diffuse swelling? Is there midline shift? How large is the infarct core? These findings correlate with how long perfusion was inadequate. Minutes matter. The circulation support technique we discussed, position and breath, is about stabilizing the internal environment. It may help maintain marginal blood flow in the penumbra, but none of it substitutes for rapid hospital evaluation, vascular imaging, and targeted intervention. If symptoms resolve entirely, that does not grant permission to stay home. A transient ischemic attack carries a significant short-term risk of a larger stroke, particularly within the first 48 hours. That window is volatile, so the hierarchy is clear. First, recognize the signs: facial droop, arm weakness, speech difficulty, sudden vision loss, severe unexplained headache. Second, call emergency services immediately. Third, support circulation calmly and safely while waiting. In the next segment, I'm going to move from crisis response to prevention, because the most powerful way to protect your brain is not what you do during a stroke. It is what you do every single morning before one ever begins. It is what you do every single morning before one ever begins. If you want to reduce your risk of ever needing that emergency positioning strategy, you must focus on one central objective: optimizing circulation before a crisis develops. I am going to break this into 4 actionable pillars. These are not extreme interventions. They are physiological supports. Number 1, morning hemodynamic activation. Blood pressure and clotting tendency naturally rise in the early morning hours. Cortisol surges. Platelet aggregability increases. This is one reason strokes and heart attacks are statistically more common shortly after waking. Instead of standing abruptly and stressing the system, sit upright at the edge of your bed first. Take 3 slow diaphragmatic breaths. Expand the lower ribs, not just the chest. This improves oxygenation and gently transitions your autonomic nervous system from sleep to wakefulness. Then begin rhythmic calf activation. Lift your heels and then your toes in alternating motion for about 60 seconds. The soleus muscle acts as a peripheral pump, assisting venous return. Improved venous return supports cardiac preload and more stable blood pressure during that vulnerable morning window. This is simple vascular mechanics. Number 2, preserve endothelial function. Your arteries are lined with endothelial cells that produce nitric oxide, a molecule that promotes vasodilation and keeps vessels flexible. Chronic inflammation, high glucose levels, and smoking impair this layer. You support endothelial health by stabilizing blood sugar, reducing ultra-processed carbohydrates, and prioritizing omega-3 fatty acids. Fatty fish, leafy greens, nuts, berries. These foods influence inflammatory cytokines and improve vascular responsiveness. This is not about dieting, it is about reducing cellular inflammation that stiffens arteries over time. Number 3, regulate carbon dioxide tolerance through breathing practice. Most adults chronically overbreathe. Shallow chest breathing reduces CO2 tolerance and can predispose individuals to exaggerated sympathetic responses under stress. Practicing slow nasal breathing, 4 seconds in, extended exhale, trains your nervous system toward parasympathetic balance. A regulated autonomic system supports stable vascular tone. Stable vascular tone supports consistent cerebral perfusion. Number 4, daily low-intensity movement. You do not need extreme exercise. In fact, sudden high-intensity exertion in sedentary individuals can transiently increase risk. What I recommend is consistent moderate activity, walking, light resistance training, balance exercises. Movement improves insulin sensitivity. Improved insulin sensitivity reduces glycation end products that damage vessel walls. It lowers chronic inflammation markers like CRP. Over time, this preserves arterial compliance. When I operate on patients with severe vascular disease, the difference in tissue quality between those who move consistently and those who do not is visible. Arteries become calcified and rigid in the sedentary inflamed body, flexible in the metabolically optimized one. Now let me be clear, these pillars do not eliminate risk. Genetics, atrial fibrillation, advanced plaque burden, these variables matter. But optimizing circulation significantly improves your baseline resilience. In the next segment, we need to discuss nuance, because not every body responds the same way. Age, medications, blood pressure variability, all of these factors influence how aggressively you should implement these strategies. And precision matters, because biology is individual. Let's talk about nuance and who needs to approach these strategies with modification. First, if you have diagnosed atrial fibrillation, carotid artery stenosis, or a prior stroke, your risk profile is fundamentally different from someone without those conditions. In atrial fibrillation, irregular atrial contractions allow blood to pool in the left atrial appendage, increasing clot formation risk. If you are prescribed anticoagulation, strict adherence is non-negotiable. No breathing technique replaces anticoagulant therapy when it is indicated. Second, blood pressure variability requires attention. If you have chronic uncontrolled hypertension, lying completely flat during a suspected stroke may not be appropriate in every case, particularly if there are signs of increased intracranial pressure, such as severe headache with vomiting or altered consciousness. In hospital settings, positioning decisions are individualized based on imaging and neurological status. That is why the primary directive remains call emergency services first. The positioning strategy is for conscious individuals with suspected ischemic symptoms while awaiting help, not for someone who is unresponsive or having seizure activity. If a person is unconscious, airway protection becomes the priority. Third, age stratification matters. For adults over 75, aggressive new exercise routines should be introduced gradually. Sudden high-load resistance training can acutely spike blood pressure. Instead, emphasize controlled, low-impact movement with consistent frequency. Balance work is critical because fall risk increases and head injury complicates stroke outcomes significantly. For individuals between 60 and 75 who are metabolically stable, moderate resistance training combined with aerobic conditioning improves endothelial function and insulin sensitivity more robustly. Muscle mass itself acts as a glucose reservoir, lowering chronic hyperglycemia and reducing glycation-related vascular damage. Fourth, medication interactions must be respected. If you are on beta blockers, your heart rate response to exercise will be blunted. Do not gauge exertion purely by pulse. If you are on antihypertensives, sudden positional changes may cause orthostatic hypertension. That morning activation routine I described should be performed seated before standing. Fifth, diabetes requires focused management. Chronic hyperglycemia leads to advanced glycation end products that stiffen arterial walls and damage the microvasculature supplying the brain. Hemoglobin A1C control is not just about avoiding neuropathy or kidney disease. It is about preserving cerebral circulation. Nutritional strategies must be individualized to maintain stable glucose levels without hypoglycemia, particularly if you are on insulin or sulfonylureas. And finally, there is the psychological component. Chronic stress elevates cortisol and catecholamines, increasing vascular tone and inflammatory signaling. But telling someone to just relax is not actionable. structured breathing practice, consistent sleep timing, and meaningful social interaction measurably influence autonomic balance. This is neurobiology, not philosophy. I want you to understand this clearly. Supporting circulation is layered. Emergency response, daily vascular conditioning, medication adherence, individualized risk management. No single tactic stands alone. In the final segment, I am going to bring this together: what truly determines whether someone recovers well, and how readiness transforms fear into controlled action when seconds count. What truly determines outcome in a stroke is not luck. It is timing, physiology, and preparation. When I review imaging after a stroke, I can often estimate how long tissue was deprived of adequate blood flow. The size of the infarct core, the degree of surrounding edema, the presence or absence of salvageable penumbra, these tell a story, and behind that story is almost always a series of minutes where decisions were made. Here is the central takeaway. First, recognize symptoms immediately. Facial droop, unilateral weakness, speech disturbance, sudden vision changes, severe unexplained headache, abrupt loss of balance. Second, activate emergency services without hesitation. Do not negotiate with symptoms. Third, if conscious and safe to do so, lie down, elevate the legs modestly, and regulate your breathing. 4 seconds in through the nose, brief pause, 6 seconds out. Remain still. Support circulation. Avoid panic-driven hyperventilation. Fourth, long before any crisis, invest in your vascular health daily. Morning hemodynamic activation, consistent low-intensity movement, stable blood glucose, endothelial support through nutrition, medication adherence when prescribed. This is not about eliminating all risk. It is about shifting probabilities in your favor. I have seen patients recover speech because collateral flow was preserved early. I have seen others live with permanent deficits because symptoms were ignored. The difference is often measured in minutes. Let me ask you something specific. Have you ever experienced a brief episode of slurred speech, one-sided weakness, or sudden visual disturbance that resolved quickly and did not seek medical evaluation? If so, that is not something to dismiss. I want to hear about it in the comments because these transient events are often misunderstood, and discussing them helps others recognize warning signs sooner. Preparation converts fear into protocol. If you rehearse the response mentally, lie down, elevate, breathe slowly, you are far more likely to act decisively rather than freeze. That calm response may help preserve vulnerable brain tissue while professionals are on the way. I am Dr. Miles Warren. My role is not to alarm you. It is to protect you from preventable loss. This information is educational and does not replace personalized medical advice. If you have risk factors for stroke, atrial fibrillation, hypertension, diabetes, prior vascular disease, speak with your physician about individualized prevention strategies. Your brain is metabolically demanding, but it is also resilient when supported properly. Minutes matter, preparation matters, and informed action can significantly influence what happens when every second counts.